Hi class, so we are wrapping up this semester talking about abnormal psychology. I've got a number of slides for you posted in Google Slides, but here I'm just going to quickly do some highlighting. There's some great videos posted as well, and I'm excited to finish up the course with you. So when you study abnormal psychology, we can call that psychopathology. Psychopathology is studying abnormal thoughts and feelings. When we discuss a lot of these things, you'll notice as I discuss or you come across different disorders, you're going to see a lot of the symptoms might be things that you qualify for, you follow. It's the combination of them looking at the duration of symptoms and the intensity of symptoms. So when we talk about disorders, think about it as a continuum. And when we think about disorders, we're going to talk about defining those four types of abnormal. And so there's the DSM is the main manual that's used, diagnostical statistical manual. And it's called that because it's going to give you qualifications for diagnosis. It's also going to give you statistics. How prevalent is that disorder? The DSM is made up of a number of different sections or parts. We're not covering everything in the DSM. In fact, I'm just giving you some snapshots for common disorders or more prevalent disorders. And if you're interested in this class, you would take, or this content, you would take Psych 266, which is abnormal psychology. So these are some of the things that we're going to be discussed and highlighted from the chapter. When we think about abnormal, we kind of think of it's statistically rare. So you'll be given those statistics in the DSM. But on average, you don't see very many people having these different disorders. It is something where you would notice that they're behaving a little bit differently than the norm. So social norms are part of this. You'll see there's an important cultural layer when we're doing diagnosing. And that's this idea of deviance. Is someone out of the norm in their behaviors? Disorders also impact your ability to function. Getting involved and interfering with your day-to-day life, that would be a big indicator for me that someone might have a disorder. It also could be the case that the individual feels subjective discomfort, so they're feeling uncomfortable about what's going on, how they're behaving, how they're thinking. It also could be, there are some cases where the individual has no awareness that what they're doing is out of context, out of order. And so it could be subjective discomfort as well for those around the individual. So I kind of put these together as the 4Ds. Definition, so statistically rare. And then there's some deviance to it, some distress, this idea of discomfort, and then dysfunction is it's getting in the way of living. And that's when we might say something's going on there. So again, this idea of cultural relativism is important. So if in a culture, eye contact might be something that's not acceptable to give eye contact, well, you need to think about that in the context of that individual as they're going through. Lack of social understanding of social cues is something connected with autism. Autism, again, that idea of eye contact, it could be just be a cultural behavior versus something else going on. So again, I've got a couple slides that talk about different prevalence rates, and we're going through, there's also, again, some challenges with the DSM. Again, it is somewhat culturally bound, and so that's something to be considerate of. And then it is based on symptoms, so we don't know why someone might have a disorder. And it does pathologize everyday behaviors. And what I mean by that is a lot of the symptoms you'll see are things you might do, but again, looking at it comprehensively, looking at duration, looking at how intensive that is. This is also the case. This is not the section to be diagnosing friends or loved ones or other people you meet. Leave that to the professionals. So when you go through, you'll see I've got some different classifications. So I do first discuss basic patterns we see within the anxiety disorder families, I'm also starting off with what we see as normal. And then again, if it's getting in the way of life, getting in the way of how you function, then we might be going outside those extreme ranges with a disorder. We also discuss a bunch of different phobias, also classified as obsessive compulsive disorder. So this is based on having obsessions, and then to kind of control those obsessions, people have these compulsive behaviors. Again, you'll see videos within the slides to view. Also, if you want to click on the videos I have posted with it, the Google Slides, these are a little bit different to give you some examples of individuals who have these different disorders. Depression is part of the mood disorders, and so oftentimes we do have symptoms of depression, but again, looking at things more across, there's different types of depression, and within that depression, we can see individuals having major depressive disorder, which used to be called unimodal perception or depression. And within that cycle of depression, we also see that we see higher prevalence rates with females, and part of that could be culturally how we internalize things. So women typically internalize more issues. So if I'm having a problem with feeling like my roommate is just being a jerk, I might ruminate about it. I might internalize that. I, again, magnify those negative feelings, which is typically a more female pattern of coping versus a male pattern. Maybe they'll go out and do something, kind of let those emotions out. And so we could say that's not internalizing, but kind of like externalizing. There are negative externalizing coping, so things like too much aggression or substance abuse. But in the most part, we see these different ways of handling problems can lead to magnification of things like depression. When we go through, part of the mood disorder families is bipolar depression. So bipolar is called bi because there's two poles. These individuals, besides having all those qualities that you might see with a major depressive disorder, you're also seeing them in periods of mania. And so mania is just extreme energy, kind of delusional thinking. Again, refer to some of those videos I have looking at that for bipolar disorder. Another disorder that you're going to learn more about is schizophrenia. Again, there's different categories of schizophrenia, but these individuals do not have an awareness that how they're thinking is not in the way of processing information. So they're unaware. People with OCD, obsessive compulsive disorders, know, oh, it's kind of silly. I do these things and I'm kind of thinking about, I'm overly concerned with cleanliness. So they have that awareness. People with schizophrenia don't have the awareness. So they might have a hallucination that people are in their house talking with them, but there really are no people. If you look, though, at their brain activity, you will see parts activated for visual, even if they don't have that visual presence. So it's very, very real for these individuals. And again, you can see some links on that. We kind of wrap up looking at personality disorders. So again, you'll see a couple videos on that. Regardless of types of disorders or even without disorders, another concern that's brought up in your chapter is suicide. And so this is an important topic to discuss and look through. I have some slides going through some information about suicide and suicide prevention. When we think about, so DSM gives us symptoms and prevalence, and how can you diagnose people based on number of symptoms, duration of symptoms, intensity of symptoms. Oftentimes we want to know, well, what is causing this? Well, we are revisiting those major perspectives of psychology, and you'll see that each one kind of carries a different lens in explaining what's going on with individuals. And so that's why you might see some differences in where someone biological might say it comes down to the neurotransmitters level. Somebody with a behavioral perspective might say, well, they've been reinforced this way or they've been conditioned in that way. Someone who's psychodynamic might be connected with more unconscious processing. and things like that. So that's a quick wrap up with chapter 15. Again, look at the slides and connect more and watch the videos. Chapter 16 connects with treatment. So again, with treatment, a lot of different things with therapeutic approaches. You don't have to be diagnosed with something to seek treatment. So if you're feeling like, oh, something's not going right, it's kind of like a fine tuning, it's okay for individuals to seek assistance in skill building or identify patterns of thinking that might not be helpful or habits that might not be helpful. So when we think about different types of treatment, you can think about it in terms of a therapeutic approach. Again, within the therapeutic approach, you're going to see is connected back to some of our 4 major perspectives of psychology. So chapter 16 goes through and explains what are the big descriptors for a psychoanalytic approach versus a humanistic approach versus a behavioral approach versus a cognitive approach. You might see therapists, they're not necessarily going to stick to one. They're actually, it's great if they're eclectic, and this idea is more tools in their toolbox. It's also important going through therapy to find evidence-based practices. Does this therapy work? Has it been tested out research-wise? And so it's what a lot of clinical psychologists will be investigating. Another connected treatment is biomedical therapy. So this could be drug therapy, also could be ECT, electroconvulsive therapy. Again, those are extreme cases with ECT, but that's also discussed in your book. So my slides go through these 4 major perspectives in therapy and some examples of when we might use these. One thing I want to highlight is a New Yorker cartoon. So one mechanic is more Freudian. Again, Freud is connected to psychoanalytical. And then one mechanic is a behavioral therapist. So again, having these different lenses and perspectives can help give us some insight into treatments or patterns of treatments and things we look for within treatments. We also see that we'll see connected back to behavioral is aversion therapy. We discussed that in your behavioral unit on learning, and that's brought back to therapies. Getting back to cognitive therapies, we're looking at changes in thought patterns. And so a common one that's used with cognitive therapy, it sometimes is called cognitive behavioral therapy as well, connecting back to what are your thoughts, feelings, emotions, and then what are your behaviors, and how are you kind of linking and interpreting those 2 things connected to what's going on in your environment. So one's the ABC model. And so that's this idea of you're going to activate the event, kind of reframe it. Then you're going to think what beliefs are going on with me with that event, and then what are the consequences of those beliefs. And so again, your book kind of gives you some examples of changing the way we're thinking about things can help us improve with different things. Connected again to that ABC, here's that example I have, which one type of ABC therapy is rational emotive therapy, and that's getting us to kind of be rational in our thoughts and to connect to a healthy side of our emotions. So if you wanted to kind of go through again, the slides kind of show you, well, what would be an unhealthy perspective cognitively and behaviorally with a breakup, and then what would be a healthy situation. And again, a therapist using the ABC would be connecting to getting you kind of changing your thought patterns and things going on. And that's what this next slide is kind of identifying. What are the ways we can change ourselves? And overgeneralizing statements, that's never good. Or disproportionately magnifying issues that really aren't to be magnified, or minimizing things that should be a bigger deal. And some of these things, again, it can be eclectic, where I'm interested in changing your thought patterns, but I might go about it using the ABC model. I might also go about it connecting back to a humanistic perspective. And so again, I have the slides on here with the different types of therapy connected to these different perspectives. But a humanistic, I know what's you need changing on and fixing, but I need you to develop that awareness. So I'm going to be very non-direct with you. I'm going to try to get you to have those epiphanies, those wow moments, those, oh my gosh, I totally was thinking about this in the wrong way moments. And again, that would be kind of an eclectic thing, kind of my toolbox. I'm taking some Rogers client-centered therapy. It also could be the case that I might take a more direct approach, and I might need to be more direct with you on what you're doing and how the change is needed. Again, that's the beauty of some therapy, is kind of working to find that. My slides also in the textbook also goes over some of those biomedical treatments. So again, I'm not going to test you on any specifics with medications, but it is interesting to know from a perspective, and that's again connected more and described more in your book. And then there's other types of techniques that are discussed in your book, like magnetic therapies or ECT therapy. So again, just a quick wrap up, and I look forward to seeing your assignments for this week.